Welcome back. Let's go through the answers to your warm-up questions. First question, what infections are caused by chlamydia and chlamydophila species? Chlamydophila psittaci causes pneumonia in patients with exposure to birds. So make sure you know the association with psittaci and psittacosis with bird exposure. Chlamydophila pneumoniae causes interstitial pneumonia or walking pneumonia. It's one of 3 organisms that cause walking pneumonia. And for chlamydia trachomatis, there are several different serotypes. There's types A, B, and C that cause trachoma eye infection in Africa. The one that's more clinically relevant in the United States is chlamydia trachomatis types D through K. These cause STDs and pelvic inflammatory disease, as well as urethritis and neonatal conjunctivitis. And the other types of chlamydia trachomatis is L1, L2, and L3, which cause lymphogranuloma venereum, causes a primary ulcer, plus lymphadenopathy in the inguinal region. And what is the treatment for most chlamydia and chlamydophila species is macrolides and tetracyclines. So either macrolides or tetracyclines. All right, that's it for your warm-up. Let's move on to the lecture.
Hello everyone and welcome to our video on the pancreas. So there's more to the digestive system than just the GI tract. So over the course of the next few videos, we're going to discuss things like the pancreas, the liver, and even the gallbladder. So let's talk about the pancreas, and even we'll throw in a little spleen embryology here. The pancreas is going to arise from the foregut. So the pancreas is derived from endoderm. Now the first thing that happens is a small diverticulum starts to develop on the distal foregut, almost at the midgut. So this diverticulum is called the hepatic diverticulum, and it develops on the ventral surface of the foregut. Now the hepatic diverticulum is going to give rise to the liver and the gallbladder and the biliary tree, and also the ventral side of the pancreatic bud. Now that ventral pancreatic bud is going to become part of the head of the pancreas. Then there's also a dorsal pancreatic bud that develops from the dorsal surface of the foregut, and that dorsal pancreatic bud will eventually become the body and the tail of the pancreas. And this part of the foregut eventually rotates and becomes kind of C-shaped to form the duodenum, and as it does so, it drags that ventral pancreatic bud with it until it meets up with the dorsal bud, and they fuse together. That's around 8 weeks. So, one developmental anomaly that we can see with the pancreas is called an annular pancreas. Annulus is a Latin word for ring. Now, an annular pancreas is where the ventral pancreatic bud basically encircles the duodenum and forms a ring around it, and it can sometimes compress the duodenum from the outside in, causing a narrowing or a stenosis of that part of the duodenum. Now, 2/3 of patients with an annular pancreas remain asymptomatic throughout their lives. Most patients that have this have so little stenosis that it doesn't really cause any problems whatsoever. Now, symptom onset, when it does occur, can occur at any age depending on the severity of that duodenal constriction. Children can present with gastric outlet obstruction and non-bilious vomiting, feeding intolerance, and abdominal distension. Now, in infants, an annular pancreas is associated with polyhydramnios, Down syndrome, esophageal and duodenal atresia, and imperforate anus, and even a Meckel diverticulum. And then in adults, these patients usually present at about 20 to 50 years of age, if they're going to present at all, and they're going to present with abdominal pain, postprandial fullness and nausea, peptic ulcers, pancreatitis, and rarely some biliary obstruction as well. But again, most of these patients go through life without any problems at all, but it's something that can present a little more often in childhood. All right, so let's continue on in our pancreas and spleen embryology. So there's something called a pancreas divisum, which is where the ventral and the dorsal buds fail to fuse at all. So you have 2 parts of the pancreas that are not fused. Now, while we're also talking here about the pancreas, what about that spleen? So the spleen doesn't come from the hepatic diverticulum. The spleen arises from the dorsal mesentery of the stomach. So it's a mesodermal structure, not an endodermal structure. But it gets its blood supply from the artery of the foregut, which is the celiac trunk. Now remember that one of the 3 branches of the celiac trunk was the splenic artery, so be aware of that. So now let's talk about the function of the pancreas. So parts of the pancreas function as an endocrine gland producing insulin and glucagon and other endocrine hormones, which we'll talk about in the endocrine videos. But right now I wanted to focus on the function of the pancreas as an exocrine gland, which delivers enzymes and bicarbonate into the GI tract. So, what enzymes are secreted by the pancreas? Well, there's lipase, there's colipase, and phospholipase A, which digest fats and lipids. Lipase digests lipids. In order to digest and absorb lipids, fats and cholesterol, you need lipase from the pancreas, and you also need bile, which comes from the liver. Now, the pancreas also secretes proteases, which are enzymes that digest proteins. So we talked about pepsin in the stomach, which started on those proteins, but there are also pancreatic proteases. Now, proteins are too big for your gut to absorb. Your gut can only absorb amino acids, maybe some small polypeptides, maybe 2 to 3 amino acids in length. So in the stomach, the pepsin starts the process of chopping those proteins into smaller, more manageable pieces. And then the pancreatic proteases break down those proteins even further into pieces that can be absorbed by the enterocytes. Now, these pancreatic proteases include things like trypsin, chymotrypsin, elastase, and carboxypeptidases. Now, the pancreas secretes these proteases as zymogens, or inactive proenzymes, and then they are activated once they're in the duodenum. Now, you wouldn't want to have active proteases in the cells themselves, or they would start digesting cellular proteins, and then you would have a big mess. So the zymogen trypsinogen is secreted by the pancreas and gets dumped into the duodenum. Meanwhile, the duodenal mucosa is secreting enzymes called enterokinases and enteropeptidases. And they come along and convert trypsinogen to the active enzyme trypsin. And then trypsin can go around and activate the rest of these proteases. So this allows digestion to be ramped up very rapidly and in the right place. And of course, your pancreas makes the enzyme amylase, which is important for the digestion of carbohydrates and starches. All right, so let's talk about that for just a second here. Carbohydrate digestion. So carbohydrate digestion begins in the mouth with salivary amylase, but then in the duodenum, the pancreas secretes that pancreatic amylase, which breaks down complex carbohydrates into simpler sugars, oligosaccharides and disaccharides. But like the proteins, these sugars can't be absorbed until they are broken down into the smallest possible units, which are sugar monomers. Now, the enzymes that do this are called oligosaccharide hydrolases, which are things like sucrase, maltase, isomaltase, and lactase. These are all found in the brush border of the intestine in the enterocytes. So these are the rate-limiting enzymes of carbohydrate digestion, and it takes place right at the last step prior to absorption. Then once the carbohydrates are broken into monomers, the enterocytes can absorb them using a sodium glucose co-transporter, which is called SGLT1. So that's sodium glucose transporter. So it uses the sodium gradient to help drive the transport of glucose and galactose into the cells. And that's a common theme throughout the body, absorbing things with the help of sodium. So that's how glucose is absorbed at your enterocytes, through that sodium-driven active transport. Fructose, on the other hand, is taken up by facilitated diffusion using a transporter called GLUT5, G-L-U-T-5. Now, one last physiology thing I want to talk about briefly is how the body tells the pancreas to start secreting all of these enzymes. Now, there are several different signals involved here. The main signal is cholecystokinin, or CCK, the hormone that stimulates the gallbladder to contract, and it also stimulates pancreatic secretion. The vagus nerve stimulates the pancreas. Remember, rest and digest means the parasympathetic nerves are involved. And then finally, a secretin stimulates the pancreatic ducts to secrete bicarb to neutralize gastric acid. So now we're ready to talk about some diseases of the pancreas, and we're going to start with cystic fibrosis. So this is a systemic disease that causes big problems for the pancreas. So we also review CF in the reproduction videos, but let's think about CF from the perspective of the pancreas. Now, all those pancreatic enzymes have to get to the GI tract. and this is by way of the pancreatic ducts. So the pancreatic ducts make their own watery secretions to help kind of wash all the enzymes downstream to the ampulovator and into the duodenum. So we sometimes call this the pancreatic juice. Now, besides all the enzymes, things like lipase, amylase, trypsinogen, and so on, the pancreatic juice contains a lot of bicarb, and that's going to help to neutralize the acid that's coming into the duodenum from the stomach, and a lot of sodium chloride. So the pancreatic ducts make the watery component of the pancreatic juice by pumping chloride into the lumen, and where chloride goes, sodium is going to follow, and where sodium goes, that's where the water is going to follow as well. And then remember that with cystic fibrosis, there's a defect in the CFTR gene. So the cystic fibrosis transmembrane conductance regulator. So the CFTR protein is a chloride ion channel. And when that gene is mutated, so that CFTR protein gets misfolded, these patients can't pump chloride into the lumen. And then sodium isn't going to follow, and then water isn't going to follow. And instead of nice kind of watery pancreatic juice, you get kind of a nasty, thick pancreatic secretions that just kind of gum up everything. Now, this mutation causes problems in the respiratory tract and affects the sweat glands. So these patients also have extra salty sweat and excessive chloride in their sweat. So that's how you do that sweat chloride test. But from a pancreatic perspective, the pancreatic ducts get plugged up with this kind of thick gunk, and they don't get all those pancreatic enzymes into the gut. So patients have malabsorption of fats and proteins. And if you have this malabsorption of fats, you also have malabsorption of fat-soluble vitamins, and that leads to problems as well. So in terms of treating the pancreatic complications of CF, these patients need to have supplemental pancreatic enzymes, and they need to supplement those fat-soluble vitamins as well. Let's move on to acute pancreatitis, another important pathology of the pancreas. So CF is a fairly common genetic disease, but you still probably won't see a ton of it. But you will definitely see acute pancreatitis. Acute pancreatitis is where the pancreas gets inflamed and starts digesting itself, so to speak. It's not supposed to do that, but when it happens, it can be a life-threatening condition. And these patients need to be hospitalized and monitored very closely to make sure the pancreatitis is getting better instead of getting worse, and to make sure they're not developing any complications. So what causes acute pancreatitis? Well, by far, the two most common causes are gallstones and alcohol. Lock that into your brain forever, gallstones and alcohol. These two things alone are going to cause about 75% of cases of acute pancreatitis. But you need to be familiar with the other causes of pancreatitis as well, and there are several good mnemonics. There's get smashed, and when I was in school and in residency, I learned bad hits, but a student from PCOM sent us the mnemonic pancreatitis, so that seems pretty apt. So the P is for hyperparathyroidism, which reminds us that hypercalcemia can cause pancreatitis, because when PTH is high, you get hypercalcemia. A is for alcohol, one of our big ones. N is for neoplasm, so like a pancreatic tumor that blocks the pancreatic duct or the common bile duct and causes all that pancreatic juice to back up and start digesting the pancreatic tissue. C is for cholelithiasis, so that's just a fancy word for gallstones. So again, gallstones and alcohol are going to be your two most common causes of pancreatitis. R is for Rx, or drugs. So there are a handful of drugs that you should remember as potential causes of pancreatitis, especially the NRTIs that we use for HIV, like didanosine, zalcitabine, and stabudine. Also the protease inhibitor ritonavir, and sulfa drugs as well. So remember HIV drugs, remember sulfa drugs as potentially causing pancreatitis. E is for ERCP, so that's a procedure, endoscopic retrograde cholangiopancreogram. Again, ERCP is where you inject contrast into the pancreatic duct in order to visualize it. That retrograde flow of contrast is not exactly healthy for the pancreas. You're pushing things in the opposite direction as well from the way they should be going, and that can sometimes cause acute pancreatitis. Now, the next A in pancreatitis is for abdominal surgery. The T is for hypertriglyceridemia, which is an important classic cause, definitely worth knowing there. The I is for infection, and that's to remind you that things like mumps can occasionally cause pancreatitis. Not that you're going to see a lot of mumps, but every once in a while. The next T is for trauma, because things like abdominal trauma, like abdominal surgeries, can potentially disrupt the normal anatomy and cause problems. The next I is for idiopathic, which is a bit of a cop-out, but around 20% of cases are idiopathic, meaning we can't find a specific cause. So the third most common cause of pancreatitis is no cause at all, or we just don't know. And then the S is for scorpion sting, which is extremely rare. In fact, the scorpions that usually cause this aren't even native to the United States, but I always like to ask pancreatitis patients if they've been stung by a scorpion just for fun. So make sure you know all those, especially gallstones and alcohol, hypercalcemia, hypertriglyceridemia, ERCP, and drugs. Those are probably going to be the most testable ones. So how does pancreatitis normally present? Well, it causes pain, severe upper abdominal pain, possibly radiating to the back. Nausea, vomiting are also big clues. These patients often refuse to eat or they have cytophobia, which is fear of food, because they know that eating is going to make the pain and vomiting worse. We usually make the diagnosis by an elevated serum lipase. Now, a lot of people check amylase too, but lipase is a bit more specific. And we usually get a CT scan just to confirm the diagnosis. But really, serum lipase is going to give you the diagnosis best. Then the reason that acute pancreatitis is such a bad disease is that it can lead to a bunch of terrible complications like multi-organ failure, that's not good, DIC, hemorrhage into the pancreas, necrosis of the pancreas. You can sequester all your calcium in the abdomen as well. When the calcium combines with fat and forms soap deposits in the belly, we call that saponification. And as the calcium precipitates out of the blood, it can cause severe hypocalcemia. And then acute pancreatitis can turn into chronic pancreatitis, and you can also get something called a pancreatic pseudocyst. And that's one reason we do the CT scan, to look for a pseudocyst in the pancreas. A true cyst is lined with epithelial cells, but these pseudocysts are lined with fibrous scar tissue, granulation tissue from all that ongoing inflammation, and they are filled with that pancreatic juice and pancreatic enzymes. Now let's switch gears and talk a little bit about chronic pancreatitis. It's classically caused by alcohol abuse because alcohol is irritating to that pancreas. And because of the chronic inflammation, you get chronic damage to the pancreas and chronic pancreatic failure with malabsorption, steatorrhea, and all those things that we saw with pancreatic failure from cystic fibrosis. It can also damage the pancreas to the point of causing diabetes. And chronic pancreatitis will also increase the risk of pancreatic cancer. Then to manage chronic pancreatitis, just like with cystic fibrosis, you're going to give pancreatic enzymes and fat-soluble vitamins. Let's move on to pancreatic cancer. So pancreatic adenocarcinoma. We've already mentioned a couple neuroendocrine tumors of the pancreas, like a gastronoma or a VIPoma. But generally, when someone says pancreatic cancer, we're talking about pancreatic adenocarcinoma. And this is an aggressive cancer that has a really poor prognosis. Now, one reason is that it doesn't cause many symptoms until it's pretty far gone and is already metastasized to the liver. Now, it classically presents with weight loss, abdominal pain, or jaundice because the tumor is obstructing the biliary tract. And that jaundice can be pretty severe and can come on pretty suddenly. Often painless jaundice as well. Now, I remember a patient who I was seeing right after the New Year. She was fine at Christmas, but by New Year she was very bright yellow. She was dead by April. Pancreatic cancer moves very, very quickly. It is pretty horrible. Now, there's also a very rare presentation called Trousseau syndrome where you get hypercoagulability and venous thrombosis and migratory thrombophlebitis. It can be associated with lots of different malignancies, but pancreatic cancer is certainly one of them. In fact, Dr. Trousseau, who first described this association between thrombophlebitis and pancreatic cancer, he later diagnosed Trousseau syndrome in himself, and then he developed pancreatic cancer, unfortunately. Now, don't get Trousseau syndrome confused with Trousseau sign, which is the sign associated with hypocalcemia, where you put a blood pressure cuff on the patient, tighten it, and then they get a carpal pedal spasm in the hand. That's Trousseau sign, but we're talking about Trousseau syndrome. Now, the big risk factors for pancreatic cancer are things like chronic pancreatitis, which we already mentioned, tobacco use, being over the age of 50 years, and being either black or an Ashkenazi Jew. Now, there are a couple of tumor markers for pancreatic cancer. CA19-9 is the main one, but CEA can also be associated with pancreatic cancer. We tend to think of CEA as a tumor marker for colon cancer, but it can be elevated with pancreatic cancer as well. It's a common tumor marker for several different gut tumors, but it's not very specific for any one organ. All right, so let's cover a couple more things. We're going to talk about a glucagonoma, which is a hard thing to say. This is a tumor of the pancreatic alpha cells, so this leads to an overproduction of, you guessed it, glucagon. Patients will present with depression, dermatitis, a very specific one, a necrolytic migratory erythema. They can also get diabetes, they can get a DVT, and even some weight loss as well. A treatment includes octreotide or just resection of the tumor itself. Another rather rare tumor is an insulinoma. So this is a tumor of the beta cells of the pancreas. So here we see an overproduction of, you guessed it, insulin, which will lead to hypoglycemia. So how do we diagnose this? Well, hypoglycemia is certainly going to be present, but how could you tell the difference between an insulinoma and maybe just someone who is giving themselves too much exogenous insulin? Well, you need to check the C-peptide. The C-peptide will be elevated in an insulinoma. It will be normal in someone giving themselves exogenous insulin. 10% of insulinomas will be associated with men, that MEN1 syndrome. And the treatment is going to be surgical resection. And then we have a somatostatinoma. So this is a tumor of the delta cells of the pancreas. With too much somatostatin, we see a decrease in the secretion of things like secretin, cholecystokinin, glucagon, insulin, gastrin, and GIP. Patients will present with diabetes, steatorrhea, gallstones, achlorhydria as well. Treatment is going to be resection again, or you might want to give a somatostatin analog like octreotide. All right, guys, that brings us to the end of the lecture part. It's time for that end of session quiz. Try to answer those questions on your own, and then we'll go through them together. First question, which hormones stimulate pancreatic secretion? So let's go through these. CCK, which stimulates both the pancreas and the gallbladder. There's secretin, which stimulates bicarb secretion. And we also mentioned acetylcholine, but that's just going to be from the vagus nerve, which is technically a neurotransmitter, not a hormone. Next, what enzyme catalyzes the rate-limiting step in carbohydrate digestion? So these are the oligosaccharide hydrolases, which are found at the intestinal brush border. Next, what are the possible etiologies of acute pancreatitis? Remember our fancy mnemonic, pancreatitis. So first we have hyperparathyroidism, so that gives you that hypercalcemia, alcohol, neoplasm, cholelithiasis, RX, so that's drugs, ERCP, abdominal surgery, hypertriglyceridemia, infection like mumps, trauma, idiopathic, and everyone's favorite, the scorpion sting. What is the typical presentation of a patient with pancreatic insufficiency? So you might see diarrhea, steatorrhea, malabsorption, weight loss, and deficiency of those fat-soluble vitamins, which are A, D, E, and K. And then what is the treatment for pancreatic insufficiency? Well, you need to limit fat intake. You're going to give pancreatic enzyme supplements, and also don't forget about those fat-soluble vitamin supplements as well. All right, so now let's run through just a few rapid-fire facts to finish this off. Painless jaundice should make you think of pancreatic cancer, especially in the head of the pancreas. Most common cause of acute pancreatitis, we said it was gallstones and alcohol. And the most common cause of chronic pancreatitis is just alcohol abuse. All right, guys, that brings us to the end of our video. I hope you learned something. I'll see you next time.